So, um, we've discussed about delay in the development after discussing about the normal development and how to assess development. So again, the objectives are the definitions and then the common causes and the clinical features, early recognition of delay, and how to approach a child with a developmental delay, the broader concepts, and overall management, and how to prevent this if we have an option. So the basic things, development is acquisition of skills and knowledge. We have already discussed this, and it is a continuous process. And what you mean by developmental delay? As I said earlier, that delay is acquisition of a specific skill below the 2SD of the mean. So below the 2SD is the one that we take it as a delay. And usually we consider this in children under 5 years because we are dealing with development up to the age of that. And of course, one has to be mindful that in a preterm baby, we correct the age up to the age of 1 year, so that if the baby was born at say 28 weeks, and if the child is 6 months, we assume that the child is around corrected age is at 3 months, so that we allow a certain time period for them to gain their developmental milestones. But we usually correct it up to the age of 1 year, not more than that. So why do we talk about developmental delay? The developmental delay and intellectual impairment both will cause disabilities in social functioning. So ultimately, our aim is to have a normal child who can survive and in the community with the normal social functioning. So areas, as I said before, motor, language, cognition, social and emotional. So the development process is a wide range of normality. When we discussed, we realized that it's a range, and in certain children there are variations. So obviously there is a wide range of normality. But however, you should have the idea of the limit ages. Otherwise, you will not be able to identify whether it's a delay or not. So limit ages are the ages that they should achieve this milestone. That's the upper age limit. And for you to assess the development, sequential observation is important. And also the normal variations, which I showed you in the previous lecture, has to be recognized. Like in bottom shufflers who may walk around 2 years but having no other concerns of any other developmental domains. So what are the etiology of this developmental delay? We have genetic causes like chromosomal abnormalities. Commonest of them is Down syndrome, which we will be discussing in a later slide. And inborn errors of metabolism, you need to know a bit about the common ones, and neurodegenerative disorders. And then environmental factors like intrauterine infections while the baby is in utero. And also the birth asphyxia, where the babies will have a damage to the brain, and postnatal meningitis-like infections. And also, not so uncommonly, the social and the emotional deprivation, where parents leave the child with the domestic who doesn't talk in the same language that they do, and also who will ill-treat sometimes. So likewise, there are social and emotional deprivations due in the very high socioeconomic class as well as the very low socioeconomic class. Regarding the perinatal insults to the brain, the commonest thing is cerebral palsy that we see, and that will be dealt with in the neurology lectures, with the neurology lectures in the neurology and neuromuscular module. So I won't be dealing with it in great detail here. So how do you assess the category? So usually you have to quantify how much delayed. So which category are we delayed? Whether it's a motor function, gross motor, fine motor, or speech, or in social and behavior. So it's mainly you have to assess the developmental assessments in different 4 domains that you discuss, and then say, okay, gross motor is 8 months, fine motor and vision is 8 months, and speech, of course, he can talk a bit more, about 11 months, and social behavior is around 9 months. So that's a varying thing. So you have to assess in each category how much is delayed. Usually in a normal child, it may have the same sort of age in all the patients. If you have a developmental delay, and we call it global developmental delay, that means almost all the areas are affected, ideally. But in the global development is mainly at least 2 of the domains are delayed. And only in specific areas. Some patients may have just a receptive or rather expressive language delay, or some may have a deafness. Some will have visual impairment, motor, and then cerebral palsy. Like in a diplegic cerebral palsy, we may have only the motor component. So if you look at this graph, if you consider this as the normal development, which has a variation obviously in this pink zone, and then the red line is a slow but a steady growth. So that means the child is achieving milestones but slowly but steadily. And then there are children who will plateau their development. You may develop slowly, but again plateaus. Afterwards, there's no development. And then some may have developed normally, but then start to regress or degenerate in whatever they gain. So that's called a regression. Okay, so these are the 3 patterns that you will have to identify when you assess a patient. So what is learning difficulties? Now the mental retardation word is no more, but I have put it in brackets in case you may wonder what this learning difficulties is, but we call it is a learning disability or difficulty. So basically, what is it? It's a failure of development of mind with lifelong intellectual impairment and accompanying disabilities in social functioning. So in a patient who has learning difficulties, he may be having difficulties with the proper social functioning. And this concept is used in children over 5 years, right? That is because the IQ testing is more reliable above 5 years and more valid above 5 years rather than when you do it around 3 or 4 years. So you have degrees of intellectual impairment or IQ. You assess in a specific way, like there are again tools to assess, and above 90 is normal, and you can see how the profound mental retardation or learning difficulty severe, the scores are like that. So when it comes to etiology, I said commonest, the genetic etiologies are there, which are the chromosomal abnormalities, like in Down syndrome, trisomy 21, which you have to know in great detail, and Edwards syndrome, trisomy 18, Patau syndrome, trisomy 13, and Fragile X, there is a Fragile X, there's a fragile site in the X chromosome, and Turner syndrome, that is X0, that means there's no Y chromosome or X chromosome, there's only one single X chromosome. So Down syndrome is the commonest with severe learning difficulties, and its incidence is not so uncommon. It's 1 in 600. The commonest one is the non-disjunction, that's about 95%. And now translocation is about 4%, and mosaicism, where you have both cell lines in one patient, is about less than 1%. So we look at the common variety. This is a normal genetic material from the mother and the father. So 46XX or XY, in this case it's XX, right? So they appear in 23 pairs. But in Down syndrome, as you can observe here with the red arrow, there are 3 21s. So this is the commonest chromosomal abnormality seen with Down syndrome. That's a non-disjunction type, right? 3 chromosomes. And how it happens is in the meiosis, especially it is considered that the high maternal age is predisposing to this condition. And one of the 21s, usually it should divide into 2, but one of the 21s doesn't go into the other cell. Therefore, you will have a 3 21s in one cell. Therefore, once the baby's mother's doesn't get divided, so that 2 21s are there, and with the father's 21, there should be 3 21s. So that causes the non-disjunction Down syndrome. So when somebody asks, is Down syndrome running in the family? Yes. When it comes to translocation, you can see that this is a 21 sitting on the 14 chromosome. So this chromosome runs into the child and then ultimately resulting in a 46XY, but there's a translocation of 21. So there's two 21s here plus this translocation. So that is a translocation Down syndrome, and this can run in the family at varying percentages. If it is 21 translocation, then you have a 100% chance of having another child with Down syndrome. What about mosaic Down syndrome? So you can see this is a normal karyotype. And here this is a abnormal karyotype. So you have two cell lines in the same patient. So this is called mosaic. These patients will look phenotypically normal or may have some subtle abnormalities. And then sometimes the learning difficulties and other problems with Down syndrome may be there in these patients. So as I said before, it is maternal age dependent. So less than 25-year-old mother may have 1 in 1,500 chance of having a Down syndrome. So that means we have seen less than 25 years. It's not, again, I wouldn't say it's very, very rare, but you have seen young mothers delivering non-disjunctional Down syndrome babies. And more than 40 years, it comes down to the incidence comes up to 1 in 100. And about 45 years, 1 in 50. So there's a higher chance of having a Down syndrome baby when you are old. So what are the other clinical features? Mostly they are recognized at birth, and usually the diagnosis is made at birth and counsel the parents. So you can see the brachycephaly or the flat occiput, upward slanting eyes, hypertelorism, protruding tongue, and low set ears in these patients. And the single palmar crease is called the simian crease, and clinodactyly, which are shown in these pictures. I mean, these things I have done with you all before, even in the basic lecture. And also there's a gap between the first and the second toe, and hypotonia. So mostly you can identify them as you see them at birth. And also, why do they get a protruding tongue? Is it because the tongue is large or the mouth is small? It's mainly because the mouth is small. Again, few pictures from your textbook: the Down's baby, simian crease, and then the central gap. So what are the other associations? So they are likely to have cardiac problems like the AV canal defects and VSD, commonest being the AV canal, congenital heart disease, and then duodenal atresia, the gut atresia, esophageal and duodenal atresia, and also they have a higher incidence of hypothyroidism and a low IQ level, and also high incidence of acute myeloid leukemia at an earlier age, and they can die of it. You have to be mindful about it. And high incidence of refractory errors of eyes, middle ear infections, secretory otitis media, so that they can have deafness, sensory conductive deafness, and also high incidence of Alzheimer's disease at an early age, and they are short. All in all, you have to look into these complications when you are dealing with a Down syndrome baby. Okay, so trisomy 18 or Edwards syndrome. It's a long, narrow skull with a prominent occiput, and they have overlapping fingers. This is the classic sign, the overlapping fingers. You can see the third and the fourth fingers are overlapped by the fifth and the second fingers. And also their calcaneus is prominent, which is known as the rocker bottom feet. They also have intrauterine growth restriction and a congenital heart disease, as in Down syndrome. In Patau syndrome or trisomy 13, they have a microcephaly, scalp defect, cleft lip and cleft palate, and the congenital heart disease. So in these patients, usually the midline defects are there. That is the scalp defect, the cleft lip, and the cleft palate. Midline is in the middle of the structure of a man, and also congenital heart disease again in the middle. So when you come into Fragile X, It's a second commonest cause of mental retardation or learning disability in males after Down syndrome. So even in males, the Down syndrome is the commonest condition where you have learning disability. They have a fragile site in the long arm of the X chromosome, and they have special clinical features. Of course, it's unfortunate that we are unable to diagnose them in infancy, but they will have a large head and a large forehead, a long nose with a prominent chin, and they will have large bat ears and macrochitism, which occurs after puberty. So in younger age group, unless you suspect it with some other clinical features, it may be difficult to diagnose with the size of the testes. And they will have features of autism like repetitive speech and mannerisms. And they are infertile, and they will have moderate to severe learning disability. So mostly when a Fragile X syndrome is diagnosed when we investigate them for a cause for this either the repetitive speech and mannerisms or learning disability. Turner syndrome, again a picture from your book. Lymphedema is noted on the feet. This can be seen even as a baby, and webbing of the neck again, which can be seen in babies, and widely spaced nipples, wide carrying angles, coarctation as a heart disease, and infertility with mild learning difficulties are seen in Turner syndrome. And Turner syndrome, mind you, now they have started on various treatment for height as well as the fertility, because we know that they are infertile and they have streaky ovaries. So by giving the hormone replacement therapy, we may be able to these girls will have their menstruation and stuff, but they may not be able to produce children, but still they will have the normal female kind of things as they grow older. Another entity in under genetics is inborn errors of metabolism. First one that we talk about is galactosemia, phenylketonuria, Gaucher disease. Sorry, there's a small printing mistake. It has to be GAUCHER, Gaucher disease. So galactosemia and phenylketonuria, the children present very early in the course of their life, and they can be like having seizures and poor feeding, weight loss, etc., and neurodevelopmental issues. So these are like special cases. So you need to feed them with a galactose-free diet and phenylalanine induced diet in these specific conditions. And Gaucher disease can be diagnosed very early as well as at different ages, because that can present differently in different children. And then mucopolysaccharidosis, again another condition that you suspect with their developmental delays and cause phases. And Tay-Sachs disease is another rare disease. So if I take you through the mucopolysaccharidosis, you can see the clinical features in this child. It's a cause phases, a large head, short stature, hepatosplenomegaly, corneal opacity, skeletal abnormalities like scoliosis and kyphosis, which you can see in this patient. You can see a kyphosis. So there is a wide varying names and types here. So you have to know about the hunter. Hunter does not have corneal opacity, so that if you remember it as hunters are hunting, so that they do not have corneal opacity. And Morque's is another condition where they do not have their learning disability. They will be normal in their schoolwork, but of course they have a lot of skeletal abnormalities. Okay. So environmental etiologies like prenatal factors, where I told about the intrauterine infections, the torch infections, and the alcohol used by the mother called fetal alcohol syndrome, specific changes in child, and radiation exposure during pregnancy, and drug exposure like anticonvulsants and other drugs that causes teratogenic side effects. So note about congenital rubella, which is very much non-existent now. Earlier we had that problem because now the vaccine is universal. We don't see any rubella patients. So the IUGR, rashes, hepatosplenomegaly, cataracts, and congenital heart disease, microcephaly, and deafness. You can see in these type of children, this eye has a cataract. So, but I think you can even forget this because you don't see it anymore. And then the environmental other factors, the perinatal factors like hypoxia, birth trauma causing intracranial hemorrhage, prematurity, hypoglycemia, hyperbilirubinemia, neonatal meningitis, hyponatremia can cause problems and cause developmental delays. So postnatal meningitis, encephalitis, post-traumatic head injuries, hypoglycemia and hypoxia. So these could be associated with other neurological conditions like other metabolic conditions, but commonly these things are the postnatal things, and also neurocutaneous syndromes like tuberous sclerosis, neurofibromatosis, Sturge-Weber, where they have seizures and developmental disability. So I think at this stage you may not know about this, or you are not very familiar about these neurocutaneous syndromes, but as time goes, when you come into your fourth, fifth years, you may see patients and learn about these conditions in a nutshell. One thing that I don't want you to forget is the endocrine causes, especially the congenital hypothyroidism. This is the commonest treatable cause for mental retardation or learning difficulty. And you have to identify it early and start treatment early. So what are the options available now? You have a blood spot that is sent soon after birth or within the discharge, 1 to 2 days of life. And then the report is assessed for hypothyroidism, congenital hypothyroidism. And if there are any major problems or any unusual reports, the parents are notified, and then you can go ahead with specific investigations to confirm it. So that's a way of screening all newborns born in Sri Lanka, which may prevent a treatable cause like hypothyroidism from going into learning difficulties and other complications. So if you can see, if you look at a baby, they will again have the coarse appearance. They will be hypertonic. They will have umbilical hernia, and they will have a protruding tongue. Now here, protruding tongue is not because, like in Downs, not because the mouth is small, but the tongue is large due to myxedematous material deposited in the tongue. So they will have a large tongue again. So dry skin, and they are usually good babies. They say, mothers will say they are not crying. They will, feed and then sleep all the time. So if they are very good dogs, you have to be worried. So like we have discussed about the genetic causes, the chromosomal abnormalities and the in-modern errors. And then secondly, we discuss about the environmental causes, about prenatal, perinatal, and environmental other factors like congenital hypothyroidism. Then there are many other reasons why these children can have these developmental delays or learning disabilities. But after doing extensive investigations of these patients, sometimes about 1/3 of cases may have no cause that could be identified. So that also we have to keep in mind that there are some minute reasons why they can happen, which we are unable to identify with our usual testing. But of course, now the whole genomic sequencing and the genetic screening has come into play, which is costly in Sri Lanka. But of course, you may be able to find out even a minute deletion or abnormality in a gene in most of these conditions that we see, as there's no cause for the developmental delay. So things are advancing. So when you come as practicing physicians, you may see a lot more than what I teach you today. So whatever it is important to recognize early and diagnose, right? So we discussed this before, how to assess the development in routine well baby checks. In the CHDR, we assess the development, and especially in the at-risk groups, we have to have a very tedious assessment. And you have to look at the physical stigmata and the dysmorphic features and any other associated findings like abnormal behavior, like the mannerisms I talked to you about in Fragile X. and also you need to go for the investigations to confirm these. So the investigations are multitude and they are very vast. So you should be focusing at what you suspect at the end of the history and examination. So again, I'm stressing here, the history and the examination is very important to guide your investigations because they are very costly at times. So this is like a list. This is not a comprehensive list, but this is a list that hospital of any other country would do. But unfortunately, we may be limited in certain testing because they are not freely available, one thing, and also they are very expensive to us. So T4, TSH are the, I have put it as the topmost because that is very important. And then the chromosomal analysis, the amino acids, etc., and then imaging, creatine kinase, copper, all those things are important. So when it comes to management, it is very important that we give proper information to parents. You have to break the news, you have to get the parental support by counseling and etc. And you have to do a genetic counseling if it's a genetic syndrome like Down syndrome to have further babies or not. And the management-wise, multidisciplinary team assessment and the services are the best, so that not just one person, but a team of people, group of people looking at this child to improve their outcomes. And then sometimes specific therapy are needed for certain conditions. And you have to look for their educational needs. So what is this multidisciplinary team? Usually at the moment they are hospital-based, but ideally they should be community-based. So it includes a pediatrician, physiotherapist, occupational therapist, speech and language, psychologists, social workers, so multitude of people, including the primary care worker like the midwives and the health volunteers in our system. So this is another pictorial view. So the baby is in the middle and all these people work around the baby to get him into his potential. So when you come to the replacement therapy, in congenital hypothyroidism, thyroxine is a treatment available in Sri Lanka, easily given, not to forget that. I stress here, not to forget. And galactosemia, as I told you, galactose-free diet, phenylketonuria, phenylalanine-free diet, but these are expensive therapies. I mean, the formulas and things are quite expensive in Sri Lanka, but still, if needed, we have to supplement. Okay, so then we are talking about the education. We are dealing with children, so we are worried about the education. So education assessment has to be done before the school entry. And there we assess whether he needs a specific school, whether if it is a moderate to severe learning difficulty. And then special class in a normal school, in a mild learning difficulty, where children can be there in a normal school. And also normal stream with a normal IQ with physical disability, like in a patient with motor disability, you could send them to a normal class, a normal stream with a normal IQ, so function as other peers, but needing support with the physical activity. So these are the things that you have to make a decision on by assessing the patient in the multidisciplinary clinic. So other cares, other management issues comes with the family because the family needs to be supported. We are seeing here a child who's having a developmental delay. So whether he needs, the patient needs respite care in cases where parents are unable to care for him. And also sometimes when they grow older and the parents are no more or parents have difficulties, whether they need residential homes. And also prognosis as adults and transition to adulthood. That's the difficult part. So when they are a kid, there is someone to look after them. But when they are older, they may not have, the parents are no more. And in Sri Lanka, of course, the parents and brothers and sisters look after this child. But once they are grown older and others have other commitments and parents die, they have to be looked into. And the adulthood is difficult for them. So how to prognosticate them as well as transition into the adulthood. So the most important part of this lecture is how do you prevent these. So improving maternal and neonatal care, like preventing birth asphyxias, meconium aspirations, and also caring for the baby, resuscitation of the newborn care is very important. And proper management of hyperbilirubinemia, jaundice in babies, how to manage. And rubella vaccination, which has actually come into a very high level in Sri Lanka. And newborn screening, which is called the Guthrie test, which does the hypothyroidism in Sri Lanka. And prenatal diagnosis in selected groups like Down syndrome for amniocentesis and chorea, especially the selected groups are the ones who are elderly females who are having a high chance of having a Down syndrome baby. But having said that, still abortion is not legalized unless the mother is at risk. So therefore, even if you diagnose or detect that it's a Down syndrome, I'm not sure how easy it is to get rid of the child. Okay, so that comes to the end of developmental delay. So maybe when I meet you in the wards, we may discuss it a bit more. And there will be a tutorial on developmental delay, which we can discuss it furthermore. So if you have any questions, you can post to me at that time. And hopefully I will arrange it with the batch rep and send you all a set of questions which I want you to answer and come up